You are very welcome to this HRB seminar in the Evidence for Policy series, where today we are going to be looking at substance use and childhood adversity. My name is Claire O'Connell, and I'm delighted to moderate this webinar, which will feature both a presentation of research into substance use and childhood adversity and also a panel discussion to follow. So the webinar is going out live, but it is being recorded and a replay will be available on the Health Research Board's YouTube page. For the live audience, though, you will have the opportunity to ask the panelists questions through the Slido app. You can see details in the chat on this call. If for any reason Slido isn't working, you can raise your hand, but we would prefer that you go through Slido if possible, and the code is 2620966. Okay, for the first section of this webinar, we're going to hear from Dr. Deirdre Mongan. Now, Deirdre is a research officer in the Health Research Board, and in her role there, Deirdre has responsibility for the Irish National Drug and Alcohol Strategies, and she undertakes research on drug prevalence and patterns of drug use in Ireland. And of particular interest for today, Deirdre has also recently analysed the Growing Up in Ireland 1988 child cohort dataset to measure the extent of substance use among young people in Ireland and to explore the factors associated with substance use. And Deirdre, you are going to present to us some of the research that you and colleagues have been doing around drug and alcohol use based on the Growing Up in Ireland study. But before you start your presentation, it would be great if you could put us in the frame a little bit about how this research came about and perhaps explain why the Growing Up in Ireland cohort is such a valuable data set for looking at patterns of use.
Okay, thanks, Claire. I suppose it first came about following an overview we published back in 2022 on substance use among young people. And in that overview, we knew there's a lot of data on substance use among young people in Ireland. So we wanted to pull it all together in one place for so be a useful document for people to use. And when we did that, we found we have a lot of data, a lot of survey data. We know how many young people drink or use drugs and so on. We have a lot of data on harm, such as treatment, number of young people who die from substance use, hospitalisation and self-harm. What we did find is that there is a number of important data gaps. So one of these was there was a lack of longitudinal analysis in relation to substance use. So by that I mean we didn't have, while we had the Growing Up in Ireland data was there, it hadn't been analysed to look at how factors in childhood and other factors may influence behaviours in early adulthood. And we quickly realised with the Growing Up in Ireland data cohort that this was a very useful untapped source of data that could provide us with really excellent insights into substance use. So following on from that, we partnered with Trinity College Dublin to undertake a significant analysis of this data. And we've looked at a number of different topics, and a number of them have been published in research papers. But today I'm just going to focus on the aspect I led on, which would be the impact of childhood adversity on substance use in early adulthood.
Great, thank you. And if you'd like to share your screen, Deirdre, you
yes,
can do the presentation.
of course.
That's great. Thanks for explaining the context of it all to us.
Okay, can everybody see that?
That's perfect.
Okay, so as I said, we undertook a number of research papers using the Growing Up in Ireland, and we've published two on childhood adversity that have been published in child abuse and neglect and in addictive behaviours. And these are both available open access on the HRB Drugs Library website if you're interested in reading further into this topic. So just to start off, why do we care about substance use among young people? Well, we know that substance use is a major health and social harm throughout the world and in Ireland. And adolescence is an important period to study because this is the peak period for initiation of substance use. It's also a very important key period of cognitive and emotional development. And it's the time in our lives when we transition into further education, employment and stable relationships. Substance use is associated with a number of harms, and these include substance use disorders, unintentional injuries, chronic diseases, and suicide. And we know from the global burden of disease that globally, among 10 to 24-year-olds, alcohol is the second leading risk factor for disease and injury, and drug use is the sixth. So moving on to adverse childhood experiences, which I'll refer to as ACEs throughout the presentation. And this is there is a growing body of research on childhood adversity and ACEs, and particularly in substance use in the last few years. So ACEs can be described as stressful or traumatic experiences during childhood that can have long-lasting implications into adulthood. They can cause a range of impairment, so they can impact the development of the nervous, endocrine, and immune systems. And this can result in impaired cognitive, social, emotional functioning and chronic physiological damage. Children who've experienced ACEs can be at increased vulnerability for maladaptive coping behaviours, such as using drugs or alcohol to help cope with life. And so this was the first study in Ireland that actually quantified the relationship between childhood adversity and substance use in adulthood. And we had a number of research questions, and these were the proportion of the GUI sample that had experienced childhood adversity, the prevalence of alcohol and drug use and misuse at age 20. We wanted to see what individual ACEs are associated with substance use. We wanted to measure the impact of multiple ACE exposure. And finally, we wanted to explore the mechanisms whereby ACEs can result in substance use. And we wanted to see if these relationships were mediated by parent and peer relationships and liking school. So here, I'm just going to give a very quick overview of the methods that we used. So as I already said, we analysed the Growing Up in Ireland cohort that 98. So these children were born in 1998 and they were recruited into the GUI study at age 9. They were then followed up at ages 13, 17 and 20. And for the purposes of the analysis I'm reporting today, we only included those young people who completed all 4 waves of the study. So that amounted to 4,729 young people in total. So at ages 9, 13 and 17, the young people were asked about childhood adversity. So in the first 2 waves, it was the guardian or parent, in most cases the child's mother, who answered the question on adversity. And at age 17, it was the young person themselves who were asked if they had experienced any of a range of ACEs since the previous wave of the survey. At age 20, the young people then were asked about their substance use behaviour. So we undertook logistic and linear regression to examine individual and cumulative ACE exposure relationships with substance use. We then undertook mediation analysis to determine if parental and peer relationships and school engagement mediate ACE exposure with substance use. And in all the analysis that we present here, they are controlled for sex, ethnicity, parental employment, parental education, and region of residence. So I'm going to talk first of all about the results, and we're going to look at substance use among 20-year-olds. So starting with alcohol use, we can see here that the majority of young people, 94%, drink. We have a very strong binge drinking culture in Ireland, and we see this here in our results as well. 55% of the Growing Up in Ireland cohort binge drink monthly and 18% binge drink weekly. Again, these are not surprising results. Our previous survey results have always put us among the top countries in the world for the frequency of binge drinking. Using the audit screening tool, we found that 1 in 20 or 5% have possible alcohol dependence. It's important to note that this is not a clinical diagnosis, as this was done by, administered by a screening tool, which is the audit. However, I think this is a somewhat worrying result, because generally it would take a number of years of drinking to develop dependence, and these are young people for whom their alcohol use is causing them significant harm in their daily lives. In relation to illicit drug use, again, it was relatively common. So 1/4 of the cohort had used cannabis in the last year. 29% had used other illicit drugs, and this was mainly driven by cocaine use. Again, not surprising when we look at our other indicators such as treatment and our general population surveys that have shown an increase in cocaine use. And we found using the CAGE screening tool that 15% met the criteria for problematic drug use. So I'm going to talk a little bit about the prevalence of ACEs in the cohort. So 6% experienced the death of a parent, 77% the death of a family member, 21% the death of a close friend, 31% had experienced conflict between their parents, 22% the divorce or separation of their parents, and 15% had reported that there was mental health disorder in their immediate family. 13% reported drug use or alcoholism in their immediate family. 2% reported a stay in foster home or residential care, and 2% reported having a parent in prison. It's important to note that the Growing Up in Ireland didn't contain all ACEs. So, for example, no questions were asked about the experience of physical abuse or sexual abuse or neglect. So it is likely that the prevalence of ACEs is higher in the population. So we looked at cumulative or multiple ACE exposure. And for this, we excluded death of a family member because this was an ACE that was experienced by the majority of young people at 77%. So we see that 14% or 1 in 7 young people experienced at least 3 ACEs, which is quite a high proportion. So I'm going to talk a little bit about the association between individual ACEs and drug use. So there's a lot going on in this table, so I'll try to explain it best I can. So where the cells are blank, that means there was no relationship between the individual ACE and the drug use outcome. So we can see that death of a parent or death of a family member were not associated with any of our drug use outcomes. We see the strongest relationship for drug taking or alcoholism in an immediate family. So we've reported odds ratios. So that means that children who grew up in a house where there was drug taking or alcoholism were 2.2 times more likely to have problem drug use other drugs, or use cannabis when compared with children who did not grow up in such families. We also see increased risk of problem drug use among those who reported conflict between parents, and children who experienced this were 2 times more likely to report problem drug use compared with children who did not experience such conflict. And we also see that those living in a house where there was a mental health disorder in the immediate family, they were also at much higher risk of problem drug use, and they were 2 times more likely to report this at age 20. We also see that there is a relationship between the death of a close friend and problem drug use, and between divorce, separation of parents and other illicit drug use and problem drug use. However, this relationship would be weaker than those seen for conflict between parents, mental health disorder in the immediate family, or drug taking and alcoholism in the immediate family. So I'm going to move on to the association between ACEs and alcohol use at age 20. And these results are quite different to what we've seen for drug use, and in some ways a little surprising. When we look at alcohol dependence, we see the odds ratios are very similar to that what we see for drug use, and with this and the same ACEs, namely drug taking and alcoholism in the immediate family, mental health disorder, conflict between parents, and death of a close friend. These are all significantly related with having alcohol dependence at age 20. And again, drug taking or alcoholism in the immediate family had the strongest association, with these children 2.3 times more likely to develop alcohol dependence. When we look at frequency of drinking and frequency of binge drinking, the results are very different and somewhat surprising. We don't see any relationship between frequency of drinking and frequency of binge drinking with ACEs. Actually, we see somewhat counterintuitive results, whereby those children who had a stay in a foster home or residential care, or who had a parent in prison, were actually less likely to report drinking or to report binge drinking. And this would be different to what we see in other countries, whereby, generally speaking, internationally, frequency of binge drinking is associated with having experienced ACEs. And I suppose what we have concluded is that in Ireland, we have very much an alcohol culture, and alcohol is a normalised behaviour. So, and particularly we've seen how we have high rates of binge drinking. So basically, young people are likely to binge drink whether they have experienced childhood adversity. They're also likely to binge drink if they haven't. When we look at the impact of having experienced multiple ACEs, we found significant dose-response relationships between the number of ACEs and substance use behaviours. So I said earlier that 14% of children experienced 3 or more ACEs. So compared with children who didn't experience any ACE in their childhood, those with 3 or more were 2.2 times more likely to use cannabis, 2.6 times more likely to use other illicit drugs, 2.9 times more likely to have problem drug use, and 3.3 times more likely to have alcohol dependence. So we can clearly see a very strong relationship between multiple ACEs and substance use, particularly problematic drug use and alcohol dependence. So I'm going to move on to talk a little bit about the mediation analysis we undertook. So the causal pathways between ACEs and how they result in substance use is not fully understood. However, it has been theorised that safe and supportive interpersonal relationships in childhood, they may buffer the impact of ACEs on mental health and substance use in adulthood. And this has been found in studies that have previously looked at mental health. Very little research has been done on this area in relation to substance use. And in the mediation analysis, we wanted to break down how much of the relationship is caused solely by childhood adversity. So the substance use, is it entirely related to childhood adversity, or is it the case that childhood adversity leads to poor interpersonal relationships, which then leads on to our substance use outcomes? So I'm just going to present the findings here for problem drug use and problem alcohol use, which is measured using the audit score. So we found for problem drug use that intimacy with father and liking school partially mediated the relationship between childhood adversity and problem drug use. And it meant that children who didn't have a warm relationship with their father, or who didn't like school and had experienced childhood adversity, these children were then more likely to develop problem drug use at age 20. For alcohol, we found that more factors mediated this relationship, and we found that among children who experienced adversity, those who had conflict with their mother, conflict with their father, less intimate relationships with their father, and who had suffered peer alienation, these children then were more likely to develop substance use or problem alcohol use at age 20. However, it's important to, we found, however, that the intimacy with mother, peer trust and peer communication had no mediation. However, it's important to note that when we did the mediation analysis, that the indirect mediating effects were modest. The proportion of effects worked to any of these mediators was not more than 13%. So we can conclude from that is that the main reason for these children having substance use behaviours at age 20 was due to childhood adversity and not interpersonal relationships. So to conclude, we could say that Ireland has high levels both of childhood adversity and substance use. 1 in 7 children in Ireland have experienced at least 3 ACEs, and these children, we can see from the results presented here, are at much higher risk of drug use and problematic alcohol and drug use. Prevention programs that aim to reduce illicit substance use should focus on these children with traumatic childhood experiences, as they are particularly at risk of substance use at age 20. We found some mediators, such as positive interpersonal relationships and school engagement, they can help buffer the impact of childhood adversity, and they may help guide the selection of prevention interventions. And finally, I would just like to acknowledge the CSO and the Growing Up in Ireland who provided the data for this analysis. So thank you very much. And I'll hand over to you, Claire.
Thanks so much, Deirdre. That's an enormous amount of work, a lot to dig into there. Very, very interesting. As you say, some almost counterintuitive findings and some findings
Yeah,
you sort of expect but quantified. We did have one question in on Slido, that you may be able to clarify for us. Was tobacco use assessed at all?
no, we didn't. We no, just drug
Okay.
and alcohol use.
Okay. Thanks for clarifying that. So don't forget, folks, you can put your questions on Slido. You've got the code there in the chat. But I'm going to bring in our panelists now. And Deirdre, you are a panelist, but you can take a breather.
Okay.
So I'm going to introduce Richie and Ross. So Richie Stafford is an assistant principal in the Drugs Policy, Refugee and Inclusion Health Unit in the Department of Health in Ireland, where his responsibilities include representing Ireland at the Council of the European Union Horizontal Working Party on Drugs, supporting the development of the new National Drug Strategy, Service and Workforce Innovation, Drug Prevention Policy, and the licensing process for Ireland's first medically supervised injecting facility. And Professor Ross Macmillan is the Professor of Sociology at the University of Limerick in Ireland. Ross is many things. He's a sociologist, a demographer, and an epidemiologist, and his research has focused on crime and victimization, child development, family relationships, and the dynamics of health and well-being over the life course. So, Richie and Ross, thank you for joining Deirdre on this panel. Richie, I might come to you first and ask you for your comments on that really fascinating presentation from Deirdre. There was a lot in it.
Yeah, thanks, Claire. It's really interesting. I suppose it's really shown the value of the Growing Up in Ireland study. I think this is one of the issues with prevention. I think it's very good to have you know, evidence-based interventions, but where it often falls down is the lack of sort of robust longitudinal studies. So I think it's really great that we have Growing Up in Ireland. We're able to track health behaviour outcomes for young people. Um, I think the really interesting thing there for me is the impact of the normalization of drug use on drug use behavior amongst young people. And we see that where young people grow up in a household where there's drug taking or alcoholism, they're more likely to engage in those behaviors themselves. And we see this just not with factors in the home, but with just broader environmental factors. When we look at kind of epidemiological stats around the world, we see where there's maybe more availability of drugs and more influence of the sale of drugs, there tends to be higher rates of use. So it's something, but no, it's a really great piece of work. And I know Dr. Margaret Brennan's been involved in as well, looking at some other aspects of Growing Up in Ireland data in terms of drug use. So it's a very rich data set. So thanks very much.
Yeah. Absolutely. Yeah, that really jumped out, didn't it? That sort of the impact of the family environment, and particularly if there are conflicts or if there are behaviors in that environment, they can have a big effect. Thank you. And Ross, how about you? What are your thoughts on the presentation?
Well, I think it was wonderful stuff. I really enjoyed reading these two papers. Um, it really is kind of it's half of the root of life course developmental social science. One part of it is figuring out what matters. The second part is figuring out why things matter. And this work really does a lovely job thinking about the deep roots of substance use in the life course. It's also interesting. So this was my bread and butter for about 15 years. I began my research career studying this stuff. And back in the late 90s, early 2000s, ACE didn't really exist as a concept. Like research was sort of spread all over the place, and we looked at this and we looked at that. So it's really interesting to see things be focused around the family more or less, and thinking about how disruptions within the family, sort of broadly conceived, have these long-term impacts. Um, when I was invited to be part of the panel, the sort of thing that was thrown at me was the idea of what's the kind of broad set of mechanisms that are here. So I thought I would just throw some stuff in. When we think about adverse experiences, the bottom line is there are things that we couldn't prevent from happening. Like if you really look at the broad set of what unites all these different disparate things, it's things we just couldn't stop. So when you think about what that does for someone, the immediate effects of it are somewhat odd. It decreases. So somewhat odd in the sense that you don't necessarily think that things that are so kind of mundane and routine and regular would have such importance. But adverse childhood experiences, they decrease trust in other people. It's as simple as that. They decrease perceptions of agency. People think that they are less powerful than they actually are. And they shorten time horizons. So people start to think about their lives as being in short chunks rather than thinking about the broad kind of patterning of the life course and long-term investments. So when I think about the key findings in this paper, the mediating mechanisms are really about the disruption of those things. So how do we have dysfunctional relationships with parents? How do we have conflict within the family? How do we end up with peer relations that aren't functional for us? And I think all of that kind of devolves back, if you wanted to kind of individualize it and think about it in the context of these ACE experiences, they're a function of the fact that adverse childhood experiences disrupt the relations we have with other people. They just change the way we think about things. So I think that's really, really important that we're starting to think about the social mechanisms. And again, good social science produces causal explanations for things. And this is that key component where we're thinking about why things matter, not just if things matter, but why things matter. Having said that, and this isn't a criticism of the current paper, it's interesting what wasn't measured. And this again goes back to my bread and butter, which is, some of the most statistically normal things that happen during early life are pure violence. And that wasn't picked up in this. And certainly in the work that I did, that was a huge, huge effect in changing or deflecting positive trajectories over the life course. Kids' exposure to violence tends to peak in the adolescent years, which is really the sweet spot for this research. And ACEs, because of their origin in developmental psychology, tended to focus more on family. And as Deirdre mentioned, family abuse wasn't picked up, but also peer abuse wasn't picked up as well. And I think that's kind of an important element in this overall story. So I'm not going to talk, and I'll leave things to talk anymore and leave things to the panel. But I just want to compliment Deirdre on the work. It was really, really nice stuff and really well executed and put together. And I think it tells us something important about developmental patterns and what can happen in early life that has long-term impacts. So
Yeah.
I
Thank you.
compliment.
Thank you, Ross. And I suppose a really important aspect of the study, as Deirdre mentioned, is that it is the first time that it quantifies, really, I suppose, those relationships between ACEs and later substance use. And I think something that really jumped out for me was that if a child has multiple exposures to adversity, then their risk goes up, so the picture gets very complex indeed, doesn't it? We have loads of questions in on Slido. Thank you so much for being such an engaged audience. I'll just go through them. What are the best interventions when a young person has developed problematic drug or alcohol use? That gets to the heart of it. What are the best interventions? Any of our panelists want to?
I'm happy to take that
Maybe,
one. Yeah. So again, like a long time ago, I worked in a service for adolescents with drug issues. So, I suppose when people are at that stage where they have a habitual relationship with drugs, you're looking really at treatment. Then it's less sort of preventative. So it's really high quality treatment. And I suppose things like adolescent community reinforcement approach is very good with young people, because whilst they might have an issue with drugs, they're not into the sort of addiction space. Maybe it's just a very functional thing for them. So like the issues we talked about with ACEs, they have a pleasure relationship with a drug. It's doing something for them, but they're not at a stage where it's a compulsive behavior, that there's withdrawal symptoms, those kind of things. So I think, in short, that it's around having a good quality treatment available to young people, which can be an issue, I think, in Ireland sometimes, in that under 18 services are very patchy, and there's only one residential under 18 service in the country. So that is an issue, but I think it's really that when you're at that stage, you're sort of looking at a very personalized one-to-one treatment. Yeah.
Okay, thanks for that, Richie. We have a question here that you can probably answer quite quickly, Deirdre. Was there any data on process addictions like gambling or gaming and pornography? Was that something that you looked at
It's
all?
not something we looked at. There are some questions on gambling in the Growing Up in Ireland data set and gaming, but I don't think they measure addiction. So, and they do ask about pornography use. So it may be possible to look at that, but I'm not sure about how detailed they are in relation to gambling and gaming, if it would allow, I suppose problematic gambling to be looked at.
Okay, Thanks for clarifying that. We have a question. How can we provide more protective investment in circumstances where it is not a priority for government and services have waiting lists and are fighting fires? That's, I suppose, a question of prioritizing. Anybody want to?
Yeah, I can go. I
Yeah.
suppose yeah, it's prevention is it's certainly an area where you need what we'd call a whole of government response, because this falls across several departments. So we're here in drugs policy unit. So our main focus is on illicit drug use and the treatment of illicit drug use. But I suppose we work closely with partners in the CD, Department of Rural and Community Development, to kind of look at developing more supportive environments for young people. Trying to create environments that support recovery also. So if people do fall into these situations, we can get them out more quickly. But it is a challenge because it is something. I think what I was like, prevention is sort of everybody's business, but the problem then it becomes nobody's business because everybody's kind of looking, well, is it your job, my job? But realistically, it's something I think for everybody. So one of the things we're doing at the minute is we have a training called the European Prevention Curriculum, Universal Prevention Curriculum. So we've rolled it out 3 times now. So that's a training for decision, opinion, and policymakers around effective prevention interventions, particularly around substance use. But the principles cover lots of behaviours. So when we talked about gambling, stuff like that, it's a lot of the same things. So we're hoping to kind of get more colleagues from other departments involved in that training, because I think it's shown value in some other European jurisdictions when decision makers engage in it. You see better decisions then around the funding of prevention interventions, and you see more the rollout of more evidence-based prevention. But again, then how do we track that through things like Growing Up in Ireland? It can take time, and time, I think, is a tricky thing when there's political capital involved, that people need to see quick outcomes and stuff. So it's about patience as well.
Yeah, absolutely, absolutely. And I mean, maybe this is oversimplifying it, but Deirdre, would you consider that, this relationship that you're uncovering, I suppose, between the childhood adversity and later substance use, this might provide a mechanism for identifying children who are
Yeah,
perhaps at risk of and getting them into those prevention sort of channels a little earlier, maybe?
yeah, and they probably need more targeted prevention or programs as well. And we found when we were doing this study, there is some evidence internationally that family programs for families at risk, they can have a positive impact. And also, I think it shows as well that where there is families where there is drug problems, and the parents have drug problems or there's mental health problems, that the children aren't forgotten, or they're part of that treatment process as well. Because, while they're not the ones in treatment, it's obvious that they're being negatively impacted by that, or by what's going on in their household.
For sure, absolutely. Which probably brings us to the next question. Now that we know this, what are the most effective ways and processes to ensure that this evidence informs policy, service planning, and also people's behaviour? So that kind of gets to the heart of the evidence for policy, doesn't it? So what are the most effective ways and processes to ensure that this evidence informs policy, service planning, and also people's behaviour? Any thoughts on that?
I can jump in there because I suppose it's very timely in that we're at the early stages of drafting the new national drug strategy. So I think from the consultations and work we've done, prevention has really been a focus, and so I expect that'll be a strong focus in the new strategy. There have been a lot of new policy developments, I suppose, definitely in the last 5 years around prevention. So there's a number of different initiatives. We had, for the first time ever, a ring-fence funding scheme for substance use prevention. It's a 3-year funding scheme. We're into year 3 of it now, actually. So 5 projects were awarded funding for drug prevention interventions. Ross is very much involved in the review of prevention systems. So that's a UNODC model that we're implementing in Ireland. I've mentioned the UPC training. We also got new money in budget 2025 to establish substance use prevention leads in each of the 6 HSE health regions. So they have a responsibility about ensuring that drug prevention is of high quality in each of those regions. And we're close to agreeing to host the European Society Prevention Research Conference in 2026 as part of the Irish EU presidency. So there's a lot happening. There's a lot happening beyond that as well. But I think we're definitely on a journey with substance use prevention in Ireland, and we're getting a lot of praise for it at a European level anyway. So, which is good to see. But again, it's how do we measure the impacts? I think that's the next step. So we maybe need to look at that in your strategy.
Yeah, no, there have been a lot of developments recently, but as you say, it takes time in many cases. We have a couple of oh yes, this goes back to what you were talking about earlier, Ross. Not sure if I missed that, but why did you exclude, for example, sexual assault, etc., as ACEs, Deirdre?
We didn't exclude them. They weren't asked about
Oh,
in
I
the
see.
growing
Okay.
up in Ireland. So, so I suppose when the study was being designed back in the early 2000s, it probably was less known, and they didn't have what would be considered all the ACEs that you would typically measure. So they didn't have physical abuse, neglect, sexual abuse, and as Ross said, the peer victimization. They did have questions on bullying, but they only asked about the previous 6 months before there were questions. So we felt we couldn't get a true measure of how many children had experienced bullying. So we weren't able to measure that like we were able to measure the ones we did include. So basically, we didn't leave any of them out. They just weren't asked.
The data weren't there.
Yeah.
Okay, yeah. Okay, fair enough. There are another couple of procedural questions, Deirdre. Were trends assessed in relation to differences such as gender, social status? Is that something you looked at?
We didn't really, but in the analysis we controlled for all of these. So we didn't look for differences. The aim was to look at overall childhood adversity, but we did control for all those factors when we were doing the analysis.
Okay, great, thanks. And there's a question here: how do we stack up internationally for the 3 ACEs or more? That was a stat that really jumped out, I think, at a lot of us. We're high at 1 in 7. How do we compare to other countries? So Deirdre and Ross, maybe a few insights
It's
there.
very difficult because there's no kind of our set of ACEs are different to other studies, and not every study includes the same questions. So it's very difficult to compare. You're not comparing like with like.
Sure.
So it's very difficult to really come up with any meaningful answers to that, unfortunately. So So
Ross, would you agree, or would you, even intuitively, would you have felt 1 in 7 is very high for 3 ACEs?
Not necessarily, life is rough. Not necessarily. And I think for some of the ACEs, you wouldn't expect cross-national differences. Everyone has parents die, everyone has family members die. I don't think there's a particularly international social structure to having a close friend die.
Mm-hmm.
So 1 in 7, I think the thing that's more kind of significant here is thinking about the pathway that's there that gets us from those 1 in 7 to substance use later on in life. And also circling back to kind of a previous question, what can we do to change things if we do recognize that changing adverse life experiences is probably pretty difficult. There's 2 things. One, I think this research is pretty important in showing us that at least 13% of the story could be mitigated by focusing on family supports and school supports. That's very clear here. That's the mediating mechanism. So if we figured out how to build better relationships in families, and better school experiences in the wake of these things, I think that would be an important policy and practice. And then the second part of it is, the story's not all doom and gloom, in the sense that the majority of people don't have these negative experiences.
Mm-hmm.
So this tells us that there's a group that we could look at there to try and understand how adverse child experiences don't translate into substance use later on. And what can we learn from that group to then think about policy and practice.
Okay. Yeah, very, very good
I think this research was great, and it really kind of pointed us in a lot of important directions in terms of how we can think about things.
Mm-hmm. Okay, it's a very interesting point there about looking about at the resilience that could be inherent as well, and in around some people. Actually, linking back to what you said there, Ross, there's a question for you, Deirdre. Why did you choose parent relationships and liking school as possible buffering factors?
I suppose going back to the initial work, we were looking at this with a view to prevention, and we want to see if, this would be an area for prevention. So try to improve peer relationships or something to work on interpersonal relationships and so on. There is research that has already looked at other factors such as personality factors, how people internalize problems and so on, that had been done internationally, but we didn't really find a lot in relation to parental relationships, friends and so on. So we just wanted to explore this area because it hasn't really been done in relation to substance use before, or not to any great extent. And again, we felt that if we could identify mediators, that this would feed into the prevention work that's going on that Richie has described.
Very good, thank you. A specific question for you, Richie. Considering the findings on alcohol, will this be included in the new strategy?
So I suppose, alcohol will have a role because we're responsible for the treatment of substance use disorders. But again, it's one of those issues. Alcohol sits across several government departments. So we know like the best buys around alcohol are around taxation and pricing. So that wouldn't sit in the Department of Health, let's say. So it is something. So yeah, there'll definitely be a focus on alcohol in terms of the treatment of alcohol. And as well, like some of the programs we're funding, like we're funding the SAFER initiative, it's a WHO technical package around community responses to alcohol. So that's been run by the Alcohol Forum. So that's something we fund from our office. But it's something we need to work with our partners in the Tobacco and Alcohol Control Unit, in health and wellbeing to focus on.
Okay. Thank you. Yes, we have a couple of questions about that, so I'll take your answer to that, to all the questions relating to alcohol. How focused are we in Ireland on introducing trauma-informed approaches in secondary schools and universities, etc.? Any of our panelists have a comment on that? Trauma-informed approaches? Ross?
Fairly new and diverse would be my best assessment of things. I think that there are schools where trauma is very important. But the idea of having kind of a broad-based infusion of trauma-informed perspectives probably wouldn't work all that well in the bigger, more suburban schools. At least it wouldn't be cost-effective or policy effective. So you tend to find it in certain locales and less so in others.
Okay, thank you. Yes, we're just coming towards the end. So we do have a question here about psychotherapy for children and young adults is given low status in the HSE, making recruitment and retention difficult. What are your thoughts? Is that something the panel want to comment on, or is it?
I don't think it's a lack of the recruitment challenges are across the HSE. So in adult services, we're seeing the same, that adult treatment services, because of difficulties in recruiting, there's been a reduction in services in some areas. So I think it's a wider challenge, I think, amongst healthcare. There's a pay and number strategy in the HSE now, which is kind of putting constraints on things. But yeah, I know the under 18 services, Professor Bobby Smith and Dr. Jerry McCartney, they're both doing a huge amount of work nationally. So their responsibility is for services in Dublin, but they've kind of created a hub and spoke model to kind of extend services out across the country. But they're two guys covering a huge amount of ground, so it's it'd be great to have more people involved in the sector, but it is a challenge.
Yeah, absolutely. Just a couple more questions. Where does the Department of Education fit? Surely they should be key partners in this. I think this goes back to the need for the whole of government approach. Is that right, Richie? Do you think?
Yeah, so the Department of Education do overall, they're very involved in the National Oversight Committee for the National Drug Strategy. And on SIG1, which focuses on prevention. So their main role is around the curriculum. So they do have the Know the Score program. There have been some challenges with rolling that out to all schools and all teachers who need it. But there is ongoing work there. So I think they are doing their bit. But I think the people's knee-jerk reaction is always when we think there's drug issues, it's like we need to do something in schools. And schools, I'm not sure the statistics, but children actually spend a small amount of time in schools. It feels like a long time, but schools aren't responsible for all of this stuff, So once they do have a role, I think we need to move away from that focus just on schools in terms of prevention. We kind of have this inoculation response where we need to go in when they're 13, 14, give them a shock, and then off we go. And that's not really how prevention works. We need to take a life course approach to prevention. And so it's not just within schools.
Looking at that bigger picture, very good. Okay, thank you for that. And thank you for all the questions on Slido. We've been inundated, so but we do need to finish up in a moment. So I'm just going to ask each of our panelists for their thoughts on what policymakers can and should really take from this evidence so that it informs policy in the future. So maybe Ross, what would your insights for policymakers be from this, or what do you think policymakers should take from it?
I think I'd go with my previous comment, which I think the research points us to two really important domains of early life, families and schools, and says that we can use those arenas to do interventions that could be very helpful here. And I'd echo Richie's point, which is that, part of the problem with schools is that they're so standardized nowadays, and they have curriculums that are well developed that use up the entire day. So for something that's outside of the box, that would be, an ongoing intervention that would help people, dealing with trauma, dealing with problematic life events, dealing with the availability of substances and so on. It's often difficult to find the space to do that in schools because of the way in which we organize them. And that's an international problem. It's not an Irish problem. So that's one part of it. And the second part of it is I really think we could learn a lot from the more successful cases that are here, and look to the chains that aren't there, the chains that are broken from adverse childhood experiences to later life substance use, and see what policy we could develop out of that. I think that would be very valuable.
Right. Thank you. Richie, your thoughts for policymakers?
Yeah, just to pick up on Ross's point, I think that is important that when we're developing strategy, we're not just looking at people who use drugs. It's a whole of society approach. So as somebody with an interest in prevention, I'm very interested in people who don't use drugs, because that's where you kind of look for the clues about why that is. And even, there's lots of people experience ACEs, multiple ACEs, but they don't go down this route. So I think that's something I'd really like to see, I suppose, from a policy point of view, is we have a lot of this epidemiological data in Ireland. So growing up in Ireland is longitudinal, but we also have kind of descriptive, snapshots in time. So we've the health behaviour in schools, we have SBAD, Planet Youth, My World that Jigsaw Run, there's others. And they all come out with different prevalence stats. So I think that the next wave of SBAD is due to be published next week for Ireland. And looking at some of the stats, it's positive. I won't give any more weight than that so far, but there's some, the last wave of SPAD was before COVID. So did COVID have an effect? But I think if we can somehow kind of compile all this epidemiology to kind of enrich it all, that'll be really good. Because we have lots of different snapshots in time, lots of different questions being asked. But if there's a way to kind of look at it all together, it might give us a clearer picture of what's going on.
Great, thank you. And Deirdre, policymakers.
Yeah, I suppose it clearly shows that, multiple ACEs is a very strong risk factor for substance use, and the ACEs we've looked at, they really focus around family dysfunction. So I think that's an important area to look at for prevention, and our mediation analysis has shown there is that, positive family relations can buffer the impact of childhood adversity. So I think that's where we need to be looking at, or trying to, I suppose, reduce the impact of adversity into adulthood, and particularly in relation to substance use.
Great, thank you. Well, thank you so much to Deirdre for the presentation, and to Deirdre, Richie and Ross for being super panelists. Thank you to you, the audience, for being so engaged as well. I don't think I've ever been on a session where I've seen so many questions come in on Slido. So obviously it's a very, very it's a topic that you're all interested in. So well done, everyone. And thank you as well to Suzanne from the HRB for all the logistics involved. Thanks so much, everybody. Enjoy the rest of your day.
Thank you.
Thank you.
Bye now.